Hi, my name is Dr. Jamie Caroon, and I'm the Medical Director at the Center for Medical Cannabis Education in San Diego, California. In this video, we are going to review a recently published clinical practice guideline based on 4 systematic reviews and meta-analyses of randomized controlled trials investigating the use of medical cannabis or cannabinoids for the treatment of chronic pain. Before I proceed, I should mention that I am on the Medical Advisory Board of CV Sciences, a manufacturer of hemp-derived CBD products. So an international panel was convened to systematically evaluate the evidence and produce a comprehensive clinical practice guideline for using cannabis or cannabinoids for chronic pain. The guideline was published in the British Medical Journal in September of 2021, and the panel sought to answer the following question. What is the role of medical cannabis or cannabinoids for people living with chronic pain due to cancer or non-cancer causes? And they concluded, spoiler alert, that if standard of care was not sufficient, that offering a trial of non-inhaled medical cannabis or cannabinoids was appropriate for adults and children living with moderate to severe chronic pain, regardless of the origin or the mechanism of pain. And they deemed this to be a weak recommendation. By way of context, as you know, chronic pain is a big problem. It's defined as pain that persists or recurs for 3 months or more. Opioids are prescribed for 1 in 3 people living with chronic pain, and there has been an increased recognition of the harms that are associated with long-term opioid use, which has fueled the desire to find alternatives. However, there's a lot of confusion when it comes to using this plant and these compounds for medical purposes. This guideline was based on a series of 4 systematic reviews investigating the benefits and harms of cannabis in treating chronic pain, and it used the grade approach to critically appraise the evidence and create the recommendations. At least one author of each of the 4 systematic reviews was included on the panel. So what is grade? Well, grade is a framework for developing and presenting summaries of evidence. It provides a systematic approach for making clinical practice recommendations, and it is the most widely adopted tool for doing this. Well, how does it work? First, the authors decide what the clinical question is, then they evaluate the evidence and they rate the quality of the evidence, and they have 4 different certainties or classifications of the evidence. Very low certainty of evidence, low certainty, moderate certainty of evidence, and high certainty of evidence. So with a high certainty of evidence, the authors have a lot of confidence that the true effect is similar to the estimated effect. And on the opposite end of the spectrum, with very low certainty evidence, the true effect is probably markedly different from the estimated effect. And in case it's not clear, the estimated effect is the effect that was observed in the study, whatever it was. It was derived from the sample that was used in that study. And the true effect is the effect in the population. So when we study a sample, we are hoping to extrapolate those results to the broader population. And the results that we see in the study are an estimate of the true effect in the population. Now, it's tempting to think that strong recommendations are only based on high certainty evidence, and weak recommendations are only based on low certainty of evidence, but that's not actually the case. You can have high certainty evidence and a weak clinical recommendation, which is actually the case in this particular clinical practice guideline. And that is, you could have really well-designed studies with large sample sizes, but let's just say the effect size is very small, And so even though there's high certainty of evidence, you might have a weak recommendation because you don't think that the effect is going to be very clinically significant. And as I said, that's the case here. And you'll see as we go into this guideline, the authors have concluded that the clinical effect, in other words, the magnitude of the pain reduction, is not really enough to warrant a strong recommendation, despite the fact that there is moderate and high certainty of evidence for some of the effects. The panel itself was comprised of a variety of healthcare professionals, including general practitioners, pain management docs, pharmacologists, pharmacists, and importantly, patients, people living with chronic pain. Fortunately, these authors and their approach to evidence-based medicine relies on the input of actual patients because patient preferences and values are important. And this is how they develop the guidelines that reflect the values and preferences of patients. They include them on the panel. So this is not just a bunch of geeks providing recommendations from an ivory tower. Actual patients and their own personal experience is being incorporated into the process. The 4 systematic reviews upon which the guideline was based included 32 randomized controlled trials with a median of 72 participants per trial. These RCTs included THC as the intervention, CBD as the intervention, THC and CBD together in different ratios, and palmityl ethanolamide, or PEA, which is a cannabinoid-like compound. It's produced endogenously. It's not synthesized or biosynthesized by the plant. And I'm not sure, frankly, why studies investigating PEA would be included in this guideline, especially because when we get to the recommendations, you'll see that there's no recommendation for PEA. With systematic reviews and meta-analyses and clinical practice guidelines, you may be familiar with this concept of heterogeneity, which is basically a word that describes differences between studies. And you're trying to summarize a group of studies, and the more different they are, the more difficult that becomes. And so here there are only 3 studies that used CBD or CBDV, that's a Varin version of CBD, of the 32. So whatever recommendations that are made, which we'll get into, about CBD are only based on 3 studies. And none of those 3 studies investigated CBD in a full spectrum hemp extract, which is what most people and most healthcare professionals are using in clinical practice. And so it's tough to know whether the recommendations about CBD that used isolated CBD products should be applicable to hemp-derived full-spectrum CBD products. Also, it's interesting to note that there's only 3 of them, and so what kind of recommendation could really be made based on just these 3 studies? And then the THC and CBD studies, of which there are 15, are mostly THC and CBD in a 1-to-1 ratio, which is a drug product that's approved in over 30 countries in Europe, called Sativex. The generic name is nabiximols. And so it's really important when we read these guidelines that we remember what they were based upon. So when we talk about the dose of CBD, for example, that is recommended, I think it should be taken with a grain of salt that it was purely based on isolated CBD, and there were only 3 studies. And all of these different investigational drug products were administered in a variety of different forms: capsules, sprays, drops, creams, etc. However, none of the randomized controlled trials included in this clinical practice guideline investigated inhaled cannabis. And one quick note here, typically when you see the term cannabis in clinical research, it refers to the plant or maybe crude extracts of the plant, which are mostly but not always inhaled. And when you hear the term cannabinoids, it typically refers to either highly purified extracts that are effectively isolates and or synthetic cannabinoids, a few of which have been approved by FDA already. Here's a list of the outcomes that were measured in the randomized controlled trials: pain relief, physical functioning, emotional functioning, role functioning, social functioning, sleep quality, opioid substitution, and adverse events. And here's what the panel had to say about the impact of cannabis or cannabinoids on those outcomes. They concluded that non-inhaled medical cannabis or cannabinoids provided a small increase in the proportion of people living with chronic pain who experienced an important improvement in pain and sleep quality. So a small increase in the proportion of people experienced a reduction in pain and an improvement in sleep quality, and this is based on high to moderate high certainty of evidence. They also concluded that the use of cannabis or cannabinoids resulted in a very small increase in the proportion experiencing an important improvement in physical function, and this was based on high certainty of evidence. And finally, they concluded that there was no improvement in emotional functioning, role functioning, or social functioning, again, high certainty of evidence. And here is a list of the adverse events that were studied in the randomized controlled trials. The list includes cognitive impairment, vomiting, impaired attention, drowsiness, dizziness, nausea, and diarrhea. And here's what the panel had to say about the risks of those adverse events. They concluded that there was moderate to high certainty of evidence that there was a small to very small increase in the proportion of people experiencing cognitive impairment, vomiting, drowsiness, impaired attention, nausea, and a moderate increase in the proportion of people experiencing dizziness. They reported that there was very low certainty of evidence for the use of cannabis or cannabinoids in reducing opioid use, as well as harms like cannabis dependence, traffic accidents, falls, suicidal ideation, or suicide, and other potential serious harms. They concluded that there was moderate to high certainty of evidence for the use of cannabis or cannabinoids in balanced ratios of CBD to THC, as well as high CBD products. There was moderate to high certainty of evidence for use that was influenced by both positive and negative social consequences. An example of a positive social consequence would be support from friends or family. An example of a negative social consequence would be the stigma surrounding cannabis use or perhaps disapproval from a healthcare provider. They also reported that there was moderate to high certainty of evidence to be concerned about adverse drug effects, addiction, tolerance, losing control, or unusual behavior. And the panel reported that the cost was too high and that the changing landscape with regard to legalization and access positively influenced patients' decisions to try medical cannabis or cannabinoids. So given that some of this evidence has been moderate to high certainty, why is the recommendation weak? Well, it's weak because it's based on small to very small improvements in these various outcomes, typically using self-reported instruments in pain intensity, physical functioning, and sleep quality. According to the panel, the clinical improvements in these areas are small to very small. The recommendations are also weak because they are based on small studies with lots of heterogeneity, meaning small studies that are fairly different from one another. And as you know, it's difficult to draw general, strong conclusions when there are important specific differences between the studies. Here is their specific guidance for adults and children living with moderate to severe chronic pain, regardless of pain mechanism. Therapeutic trials should start with low-dose, non-inhaled cannabidiol, or CBD, gradually increasing the dose and the THC level depending on clinical response and tolerability. So this part is confusing. If you recall, there's only 3 studies included in all 4 of the systematic reviews that served as the basis for this clinical practice guideline, and they all investigated isolated CBD. So this notion of increasing the dose of CBD gradually with a corresponding increased level of THC is only related to products that also contain THC. I'm not exactly sure which CBD products they're referring to here. Obviously, they're not referring to CBD isolate products, which were the products that were used in the 3 studies that investigated CBD. So that's confusing to me. So perhaps what they're referring to are CBD dominant cannabis or marijuana products where there's a much greater dose of CBD than there is THC. They go on to say here in parentheses, starting at 5 milligrams of CBD twice a day and increasing by 10 milligrams every 2 to 3 days to a maximum daily dose of 40 milligrams of CBD. And then if the response is unsatisfactory, clinicians may consider adding 1 to 2.5 milligrams of THC per day and titrating by 1 to 2.5 milligrams every 2 to 7 days to a maximum of 40 milligrams per day of THC. So they recommend a max of CBD of 40 milligrams, and if that doesn't get the job done, then to bring on THC in small increments up to a max of 40 milligrams. Again, this is a weak recommendation. And in fact, this guidance very closely resembles a recent consensus recommendation of 20 experts worldwide in which CBD is recommended as a first-line therapy, if you will, up to 40 milligrams. Now, when I read this consensus recommendation, I found it a bit arbitrary, and I disagreed with the 20 experts, and I wasn't the only one. In the same issue of the Journal of Cannabis Research, which published that consensus recommendation, which, just to be clear, is distinct from the clinical practice guideline being reviewed in this video, some prominent investigators took issue with the Delphi process that was used to arrive at that consensus. They wrote that this method should not be viewed as a substitute for randomized controlled trials, which makes a lot of sense. I also have another issue with this notion that CBD should be a first-line therapy. It suggests that there is equal evidence in support of each of these compounds as analgesics, and that is simply not the case. There is considerably more evidence in favor of THC than there is CBD. The vast majority of evidence in support of CBD as an analgesic is in the form of preclinical studies. You'll be hard-pressed to find more than a handful of studies investigating CBD as an analgesic in humans. Most of the data comes from preclinical studies. Here's one of them, however. This is the so-called CANBAC trial, which was published also in 2021 in the Medical Journal of Australia. It randomized 100 patients presenting to an emergency department with acute low back pain to either standard care or standard care plus 400 milligrams of isolated CBD or placebo. Now, granted, this is acute pain, not chronic pain, but I think it's relevant enough to include here. So as a reminder, the weak recommendation in this clinical practice guideline is to increase the dose of CBD up to a maximum of 40 milligrams. And the CANBAC trial administered 400 milligrams of CBD. Now you can see that there's no difference in this figure here between CBD in the blue bars and placebo in the red bars. Now there's a large group of people, scientists, clinicians, consumers, who will criticize this study because it used isolated CBD and not CBD in a full spectrum extract with other phytocannabinoids and terpenes and terpenoids and other compounds. And these people will point to the entourage effect as a critically important factor in terms of the effectiveness of CBD. The truth is that we don't really know whether CBD in a full spectrum extract outperforms isolated CBD at a much higher dose in a randomized controlled trial in humans with pain, either acute or chronic pain. I have not seen that study. I don't think it's been published. And so the truth is we really don't know. There is a belief that you can use a lower dose of CBD in a full spectrum extract and achieve the same outcome or perhaps even a superior outcome. But there's a tremendous amount of mythology in the world of medical cannabis, and so we don't yet know if that is simply a belief or whether it's rooted in solid evidence. But many are starting to wonder if it's time to reset the expectations around CBD, especially as it relates to pain. This editorial was published in the same journal along with the CANBAC trial. A few final considerations from this clinical practice guideline. Prior cannabis experience should be assessed before initiating therapy. If your patient has been impaired or has been high before as a result of using cannabis, they are less likely to be anxious or decide to go to the emergency department if they feel overwhelmed or intoxicated. The panel advises to monitor adverse events carefully, especially when initiating therapy and increasing the dosage of THC. Because of the uncertain effects of THC on neurocognitive development, they recommend using CBD predominant preparations, especially for kids. Also, due to uncertain evidence of harms, they advise encouraging pregnant and breastfeeding women to avoid using cannabis and cannabinoids, and that includes CBD. And finally, probably to no one's surprise, they advise avoiding heavy machinery or driving a car when using cannabis or cannabinoids. Other considerations. The panel recommends following up with unexperienced users at least once a month and experienced users after 3 months. They recommend reducing the dose to a previously tolerated dose or increasing the dose of CBD or changing the route of administration if the benefits are not sufficient or if the adverse events become problematic. They recommend discontinuing if the therapy is not helping the patient. There is a cool infographic that is available at the web address located here at the bottom of the page. This helps to walk users through some of the finer points of the study. A few final thoughts here. The evidence base for cannabis and cannabinoids in the realm of pain and frankly any other condition is filled with heterogeneity. The randomized controlled trials are generally pretty small, and there's a wide variety of drug products that are used in these clinical trials. So hemp-derived CBD products that are full spectrum represent a tiny fraction of the evidence base that exists for, let's say, chronic pain. But those are most of the products that people are using. And it's not clear that isolated CBD product has different effects than a full spectrum hemp product that would be deemed a CBD predominant product. There are also marijuana-derived products that would be deemed a CBD dominant product that have more THC in them than the hemp products. And then there are marijuana products that would be not considered CBD predominant, but that also include CBD and THC in different ratios. And so it's really confusing to draw firm conclusions when we don't have enough data using standardized drug products to compare. Obviously, more research is needed, and we need to be able to flush out some of the differences between these various drug products in the realm of pain and beyond before we can make strong clinical recommendations. And what also complicates it is that there is a tremendous amount of variability in the therapeutic response. Some people benefit greatly, some people do not. And it's the same with adverse effects. There are some people that experience adverse effects with very low doses of THC, and some can tolerate high doses of THC. Some people experience adverse effects with low or moderate doses of CBD. And so that also makes it very confusing. And then finally, there's a high risk of bias, given that many of these trials are using subjective reports and that it's difficult to mask these products. So people are generally aware of what they're using. And given the mythology that exists, it's often difficult to know whether to trust that subjective report. Thank you for your time and your attention. If you have any questions or feedback, please email me at jamie@karoon.com. Thanks for your time.
You can find more videos like this at drjournalclub.com.